So good morning, I think still. And thank you very much for the invitation to be here. I'll just briefly introduce myself and tell you why I'm standing up here. My name is Deb Stein. I'm a trauma surgeon and surgical intensivist at the University of Maryland. And I got involved with a really, really wonderful project that, for those of you who haven't seen the flyers in front of you, in the Injury Research Engagement Panel, or was started as the Injury Research Engagement Project, collaboration with amongst Center, a bunch of Trauma Survivors Network, HAVI, the ATS, and we got involved in this project to really put together an injury research engagement panel to help inform trauma research going forward. And as part of that, some of these individuals who've volunteered their time today, thank you all so much to be here, came out of that project. So that is available to all of you for shameless plug in there. But it's really been just an honor and a privilege to be up here to not only work with these individuals, but to get the opportunity to really think more strategically about how we incorporate our patients and their caregivers in how we develop all of our materials, whether that be research focused, guideline focused, patient care focused. So a little bit of a tag off of what Dr. Dicker and Dr. Berry were already talking about. So if it's okay with you guys, I'll ask you guys just to introduce yourselves. So if you wouldn't mind, go ahead and start. Kelly?
And if you can press it so it turns red, and then we'll just remind ourselves to get real close for our remote colleagues.
Thank you. I'm Kelly Lang. I'm from Northern Virginia, and I am the parent of a child who had a traumatic brain injury at age 3. She's now 25, and my brain injury was diagnosed later. So I've been through the trajectory of over 22 years caring for her and her needs, and also taking care of the rest of my family who are also traumatized by the incident or accident. And then my husband and I co-wrote a book, The Miracle Child, Traumatic Brain Injury and Me, about our story and about our experiences navigating this brand new world.
Thank you, Kelly. Jeff?
Hi, I'm Jeff. I'm a minor trauma survivor, and I walked in to the emergency room, got kind of okay treatment, and my life changed because there were complications, and I have recovered incredibly, and I have a whole lot to be grateful for. So I'm able to be the voice of those other patients laying there and wondering what life is going to be like.
Thank you, Jeff. Alexis?
Hello, I'm Alexis Hymen. I am a trauma survivor from a motor vehicle crime, and it was just a year ago. So I'm only at the beginning of my journey for trauma patient advocacy, but thank you so much for being here and your willingness to listen to everything that we have to say.
Yeah.
Hi, I'm Vonda Baden Bates. My husband died from a hospital-associated venous thromboembolism after receiving surgery for a brain injury about 12 years ago. And he also happened to be a leader in the trauma-informed area of equity. So I bridge those two things together.
Thank you all so much for being here. I hope you don't mind. First names are okay. Please call me Deb, please. Dr. Stein's my dad, freaks me out a little bit. Well, if you don't mind, I'm just gonna go a little bit off script here, because what I really want to find out from you all is how good or bad a job have we all done as guideline writers with respect to including your opinions, your thoughts, your perspectives. Alexis, you want to start for us? Just have you been involved in anything like this before? Had the opportunity?
I have not,
Does
but
anybody?
I got this job. I got involved in a research question a few years ago. They asked trauma survivors to come in. Some doctors were going to do a study, and I said, huh? They explained it, and it makes sense. So they were very patient and understanding about how to make it make sense to me and to the others that were there. They called a little bit later, said, hey, do you want to keep helping us? So we just finished the study, just got published, and Sheila, who is here, helped lead me through the process of getting my voice heard, of being listened to. And I thought, oh, this is the way it's done. And then I found out it's not. So let me help lead the way for it. I don't want to be involved in more. I want to hold the door open for anybody else.
Great, thank you. Yep.
I've been involved in the disability community doing research and also with the brain injury community and with patient experience. And how being involved with the Trauma Survivors Network and, telling our stories and how the stories matter.
Thank you. Vonda?
I went to the hospital first to try to engage the administrators there and was quite unsuccessful. But it led me to groups like this, the Patient Safety Movement Foundation. Minnesota has a patient safety, as many other states do. So I've been very involved over the last 12 years.
Thank you. All right, so let me start off by asking you all to perhaps share some experiences that you may have had as patients, as caregivers, in which you felt like there was not as much cohesion amongst your healthcare team as you would have liked, and whether or not you think that there would be some way we could all put together a guideline that would help mitigate some of that. When things just weren't going well, is there something that, how should we have done things differently, and how would that have potentially affected? Go ahead.
Most of you know what the patient looks like in the bed, but some of you know that the ceiling gets blurry at night when we start crying. And hope just fades away. And one of the other trauma survivors refers to it as that little itty bitty shitty committee gets on your shoulder and starts whispering in your ear. And the only advice that made sense to me was just hold on till dawn. Because sometimes things are not as dark as they seem in the middle of the night. But not understanding the struggle that I'm going through. I'm not who I used to be, and I don't like this. I don't want to do this. I want to reset to going back to sleep and not waking up. And then for people not to be aware that I was having that struggle. And it took a 4-year-old to come in and sit on my belly and play with my mustache to make me realize it's okay going on. It's okay to keep trying. But the disconnect between what I was being told and how I was feeling is very strong.
Great, thank you for sharing that.
As the parent of a child who was in the PICU, all I needed was a little empathy and a little bit of, someone sitting down next to me, looking in my eye, and first of all, asking if I was okay. I was in the accident, and I never got that. And all the communication was very abrupt. And, I understood everyone was busy, but I felt that my daughter mattered just as much as every other, pediatric patient on the floor. And just trying to understand where the caregiver is coming from. We don't have, a lot of us don't have the medical lingo. We, are still going through this whole trauma in our minds. I mean, it even goes down to the residents questioning me about, the child's car seat and what, did I properly strap her in? And, all those things, which didn't help me in any way at that particular moment in time. But I just keep coming back to empathy about just validating what the caregiver or patient is feeling at that time and just giving them care and concern.
I guess from my personal experience, I can piggyback off of that a little bit. In terms of just like cohesion and care and communication, I was in a position where I thought that I was just going to go home and I wasn't going to have any serious issues, surgery, what have you. And that was premature. And and I guess maybe me not knowing guidelines as much as you all or my fellow patient, survivor, family members here know, maybe it gives me a fresh perspective, but there should be a way for all of the providers to communicate, and maybe it should have been done before communicating to me exactly what my care would be moving forward. So, without the additional look at my x-rays and communication amongst the professionals, I probably would have been home and then had to go back to the hospital to have surgery. So that was a pretty big one. And then just along the lines of immediately upon getting to the hospital, for me, it felt like there was a disconnect between law enforcement and the reason that I was at the hospital, so the medical staff or the medical care team, and I don't know if there are guidelines with how to deal with law enforcement to maybe separate the two so that I could get the care that I needed before an investigation were to happen. That would be very helpful.
There are two areas that I would suggest. One is in the defensiveness. We see it in the medical records when you go through it with a fine tooth comb, just a lack of accountability, a passing of the responsibility. There was a lot of actual kind care throughout the 13 days that my husband was hospitalized and died on the 13th day. However, we confused that kindness with quality, with capacity to actually diagnose properly, expediently, and so on. So those two things really stand out for me as areas where I think collaboratively we might be able to work well together across our areas of perspective to arrive at some guidelines.
So I guess I'm hearing kind of three themes, and please correct me if I don't want to misstate anything that you all have suggested, but one thing which very prominently and very, very eloquently, Alexis, you're speaking to with respect to dividing up my medical care from what else happened to me at the time of my trauma. And trauma is, unlike many other diseases, is often surrounded by things like violence or crime or other events that may in fact bring in other people like law enforcement. And so really making sure that we do a better job of kind of separating those out. And then this issue of kindness and compassion and empathy. And I'm curious to know, could you help us strategize about how would you systematically begin to get our providers to do that better? Is there, I mean, it's like teaching people to be nice, right? It sounds a little funny, but is there a way that you can think of, were there particular people who did it well, particular people who did it poorly? And what was the difference, if you know?
I think just teaching, I actually work with the Nova Fairfax about the patient communication. We're training nurses, surgeons, and now medical students about how you communicate with the patients and their families. So giving them space, not like abruptly saying, your daughter needs to be transferred immediately because she no longer needs acute care. I had no idea what they were talking about. And then she got up and walked out and left me hanging with, what do you mean she's still in a coma? She's not awake. How do you mean she's going to be transferred? And giving us that space to process the information and then to ask the questions we need to ask, and giving us that time to do that, and not rushing from room to room. I know everyone's in a hurry, but just give us a little bit of time to process. It's an awful lot of information at the time. And looking back, and I've read through all the medical records over again, and looking back, yeah, I was angry. I wasn't at my best, but I also had just survived a trauma. And I was trying to do whatever I could do to get my daughter to a place where we could bring her home. And that meant bringing in other people.
Anyone else have thoughts on how systematically we could address this issue of communication and empathy?
One of the biggest disconnects for me, much later, when I realized that my treatment was not what other people got. I say I had an okay surgeon, his name is Scalea, he kind of knows what he's doing. I got treated at shock trauma, kind of a pretty good place to be. But that's not the average. That's not what most people get. I have a cousin in Western Kansas who has to go 70 miles to get a dressing changed. We can't put a shock trauma on every zip code, but we can reduce the amount of time for decision making by establishing those protocols that you can go to and that are then referred to. It's no good having a list in a book that nobody looks at. But I was hearing teleconferences. You don't have to know everything. You have to know where to find everything. And that's what I think the value of establishing this. What the disconnect that I found was that other people, by just sheer bad luck, don't get treated as well as I did. And now let me be the voice saying, please help him.
Thank you for that super tangible, concrete example of how we can move forward with this. Anything else from Vonda or Alexis around this?
I couldn't agree more. It was 2 days and then maybe the morning of my scheduled surgery that I had to like claw tooth and nail to try and speak to the surgeon before having the procedure. And for me, it's just like a certain level of compassion, even if the surgeon had just come in to ask me how I was doing, to develop some level of relationship with me would have totally changed my experience. I mean, I delayed my surgery a day just because I hadn't yet seen him. And then upon that, I had all these questions going through my mind about my care and my future and what I would and wouldn't be able to do that maybe he couldn't answer, but he could have just been there to answer. And I agree. I had a very, I'm very fortunate that I had a very good medical care team, but there's just a level of like being personable and asking questions, even asking like, how are you? Are you okay? These are little things that really go a long way.
At the hospital where my husband was, conflict navigation was continuously an area for improvement for that hospital. And I think it's true for most systems. And it can err on the side of being nice rather than help or than actually engaged in the care. Mistaking, my husband used to call it being, he'd prefer to have people be real than good. There's no doubt whatsoever that most of the experiences that I've had, both in that hospital as well as my own care, other family members, hearing stories, dozens of them over the last 12 years, there's a paternalistic nature that sits at the core of medicine right now. That's an intrapersonal and an interpersonal experience. We have to actually work with that. It's built into some of the bias trainings that hopefully everyone's receiving. It's built into some of the conflict navigation trainings. I don't think we can overemphasize the importance of individuals being able to work with their own intrapersonal trauma, whether they're giving that care or receiving that care, and how that plays out interpersonally as well as organizationally.
Thank you. I want to follow up on something, Alexis, that you also mentioned with respect to your providers seemingly, and again, please correct me if I'm misstating anything that you said, giving you different information, that you didn't feel like the information was necessarily as consistent that you were receiving. Did I interpret that correctly?
Yes, like original diagnosis.
Okay. And in your mind, can you imagine, again, a systematic way where we as a trauma community could try to avoid that? And I think you mentioned one thing, which is obviously just good communication ahead of time before we walk in your room. But how do we reconcile that with also being sure that we're being prompt and being responsive to your needs? Any thoughts about that?
I've thought about it a lot. The best thing I could come up with was more communication like amongst themselves, but just knowing where they're at in the step of like which step they're at in the process of evaluating the situation is very helpful. I don't necessarily need answers. I'm not someone who necessarily need answers. I just want to know like what's happening. And, I've thought about maybe more opportunity for patient advocacy. Does it have to necessarily be a medical provider? Could it be someone else, a totally different role within the medical system? Might already exist.
Yeah, great suggestion. I'll follow up with what, oh yeah, please go ahead, Jeff.
I saw something recently that I thought worked real well. I was visiting patients and the team came in to see the patient. And at shock trauma, they wear pink scrubs. That's why I have my pink shirt on. But at the end of talking, they said, have you written down any questions for us? Which was kind of that cue that go ahead and write them down when you think of them and bring them to us. That way you're not on the spot. Any questions? Okay, no good, move on. But we're going to listen to you. The team has to go through, it's a teaching hospital and there's a lot of information to share. But teaching the students that you need to listen to the patients and look at them instead of just at the chart. I saw that and I don't remember who it was, but it really struck with,
Yeah.
stuck with me.
I just curious, did any of you, this is something that has become more commonplace, particularly in the ICU. And so some of you as patients may not have recall your ICU experience nearly as well as our caregivers might. But did anybody experience where the team actually did their clinical communication, i.e. their rounds in front of you or your family members? Are you familiar with that as a concept? Was that helpful to you at all? Was that more confusing? Yeah, please.
Well, in my instance, they did not do it in front of us, but they did it right outside the door and there was a big window and I could see them, but I was not allowed to leave the room to listen. I was not allowed to be a part of the conversation or even hear what was discussed. And it wasn't until we were getting transferred to the inpatient rehab that they allowed me to sit in the back with my daughter in the ambulance. And I asked the ambulance worker, is that her medical file? And she said, yes. And I said, can I read it? And she goes, I'm normally not supposed to let you read it, but I'm a mom. So here. And that's where I learned that she was code blue. No one had ever bothered to tell me that. And I understand the hard part about patients don't always hear what doctors are saying, but I would swear on any stack of Bibles, no one ever told me how serious it was. And that no one expected her to make it from the hospital we were first taken to the trauma one. Now, we were lucky in that we had a trauma one within 30 minutes. If we had been further away, she might not have survived. But I just think having that information is key.
I could name 3 different instances where there was a group of physicians or medical professionals who were helping and did that in front of us. And it was a wide range of effectiveness and helpfulness. There were situations where they were doing it and they were arguing and they were not able to be coordinated at all in their communications. You could tell there was tension. There was actually even blame in that situation. Upon his death, I would say there was a clear communication with both me and 2 other family members while my husband was dying, while they were trying to resuscitate. It seemed like one of the most organized, effective, everybody's in teamwork together, even though they weren't able to save his life at that point, it was too late. And then there were other times when they would bring in multiple professionals from different areas to try to arrive at a diagnosis where they genuinely were listening to both my husband, myself, as well as to each other, trying to identify what the next steps would be. So it was a very wide range.
Interesting.
I think your experience highlighted something that's very important. You can look at the medical record, you can look at the tapes, maybe they did explain. Did she understand? Did she appreciate? Did they communicate? No, they said it. Did she hear it? Did she understand? Did she appreciate? They probably didn't even say it, but even if they did, they didn't communicate.
I mean, from my situation, the emergency room was so filled that I was sitting in a mobile bed that was right outside the nurse's station. So I heard like diagnoses of patients that wasn't even myself. And just a consideration is, my anxiety was probably at an all-time high for the situation I was going through, let alone now that I have to listen to like diagnoses and pretty traumatic diagnoses or instances of other individuals was also very stressful for myself.
I want to switch gears and ask you a little bit about if you, in your particular circumstance, if there was a guideline that was out there and your providers didn't follow that guideline, but rather were doing something different, would you find that intrinsically problematic? Or would you recognize that they're just different ways of doing things? Just because I think as we talk about guideline implementation widely, we want to make sure that as the rural group, I think did a really nice job of highlighting, we have to work within the system within you're working, and we don't want to give you a level 1 major urban trauma center guideline in your level 5 trauma center in the middle of nowhere that they can't possibly go by. What would that make you feel as a patient or as a caregiver if those were not concordant?
I became aware about a year after my husband died that research around hospital-associated venous thromboembolism had been studied since the 60s. We knew what to do at that point. It was the implementation that had not happened. And I would say that, 40-something years of time is sufficient enough for something like that to actually be implemented. So what was my feeling? My feeling was, how could this possibly happen? And then to make matters worse, when I began to ask questions about it, a lot of the times what I would receive is, well, that's just medicine. It takes 17 years. There's this apathy that I think is often part of that defensiveness of course, everyone wants the right thing to happen and wants the guideline or the evidence-based research to actually be implemented at the right time in the right place with the right person. When that doesn't happen, I think there is an individual trauma that happens because they're not able to actually deliver on your or our shared goal of doing the right thing at the right time. And that is something that I think if we worked with specifically the impact of that, it would help us advance more quickly the actual evidence-based research when we
So
get
you're
it.
really focusing more on the implementation aspects. The data should be there. It's really about how do we implement it and get it to the bedside. And
That, and also, we don't know how to learn well with each other. So it's not that in the 60s, it was done deal. Many people in this room, Elliot, for example, I know, continues to do research on VTE. It's that we have to be in a constant learning mode, but we also need to really be able to rely on and trust that we are offering the best that we know at that moment, at that juncture, and that we are going to continuously improve that over time. There's no destination.
I think another part of it, in addition to empathy or apathy, is inertia. We know we could do better, but this works, or we're not going to get blamed if we follow these guidelines instead of change things. It's just, our study just got published. We found something that's important and that will make the difference. How long will it take for everybody to get the benefit?
I'm fine with going against the protocol as long as you can tell me why a medical person feels that it's a better way. Give me some examples of why you want to do it, want to go that route rather than, when you want to do plan B rather than plan A. I'll totally be on board with it. Just give me the information I need to make an educated decision.
so how do we better engage people like you? How do we do a better job as a community, bringing people into these types of conversations? One of the things that struck me when we first started doing the IREP project was I thought people out of the goodness of their heart were just sitting around waiting for me to call them and be like, hey, you want to come to this meeting? Because they had nothing better to do, right? Like, I don't know. But recognizing that people's time is valuable, their experience is valuable, we need to value that as we move forward. So how do we engage the community of people that we're trying to serve so that we can serve them better? Any thoughts on that?
I was referred by a friend who's a trauma surgeon. So it seems like you have to either be seeking it out or know someone. But I think that, just like a survey at the bottom of a receipt, you're going to get such a biased view of things. If you're just getting your information from individuals who are proactively like seeking it out. So just a national understanding or education to providers that there are outlets or there are resources to communicate. Hopefully it's two-sided where they benefit as well. I'm not talking monetarily, but maybe there are other services that someone could use as part of it, giving their story and their information. But there need to be more, I guess, more ways to seek out this service or this information.
It takes time to develop the trust and relationships. one of the things that I appreciate about this particular conference is that it's iterative. It's not intended to resolve it in this one event. The other thing is that I think we're missing administrators in the equation of it because there's really a large role to play in how we learn together, how we face conflict together. And I think bringing that into the room would be very helpful as well.
When you say administrators, are you talking about hospital administrators? Are you talking about regulatory folks, both?
Both, but let's start with hospital administrators
Okay.
for this particular space. And I forgot the one piece that I wanted to say there, which is it really does help to learn how to listen. That taking the time to know how to listen and absorb and integrate, just as we want to integrate and implement research and evidence-based policies and guidelines, we want to integrate what we're hearing. Stories help with that. The approach that you're taking helps with that. And the last thing I'd say is never, ever, ever just have one patient voice be the one quote unquote, representative for that. That really is not an equation that will work out well, probably.
I very much second that. I'm loud. I take up all the oxygen in the room, but I'm not always right. My wife will tell you that.
Exactly.
I think that outreach is really, across the board is hard. It's finding the right people at the right time. And there's been a lot of conversation about when do you get in touch with a former patient? When do you reach out to them that we're here for you? And I don't actually know the answer, but that is a conversation in a lot of different arenas I've been in is like, when is the best time to reach you? And I would have always said, in the PICU is not the best time to be reaching a patient because they are so overwhelmed. In rehab, maybe, but maybe not. And I probably received a lot of information I threw out because I was so overwhelmed. I'm really not sure what the right answer is, but that is something that would be valuable to look into.
I've actually thought about it. It's kind of like backing out of a parking spot. You're looking in the rear view mirror trying to get back to where you were. And then you realize you can't get all the way back. Amputations don't go back no matter how hard you want. And you realize sometimes you just get very depressed and you start looking at your feet and say, I can't go on. And then somehow, some way, you learn to look forward. And it's not a time dependent thing. Some people start looking forward a couple of weeks later, some 10 years later, some 15 years later, some never. But you want to engage that person that is not trying to go back, but can see going forward. Life is different, but it's not over. And how do you define that? That's probably a bigger question. Somebody that can look at not just how do I get treated better, but how do we get treated better?
So I think you just made me concerned that we're gonna not be, I mean, concerned in a bad way, but in an introspective way about your points well taken, right? Everybody's on their journey. Everybody's in a different place in their journey. It's not time-based. It's not location-based. It's unfortunately very personal to every individual. And so we want to make sure that we're respectful of that because the last thing any of us would ever want to do by including patients and caregivers in these conversations is re-traumatize people. And so thoughts about how we can, I mean, obviously voluntary participation, but other thoughts about how we can avoid bringing things up that might potentially be traumatizing, or if we do, what can we provide for you all that would be helpful in minimizing the impact of that in your own psychological health? I really worry about that with a lot of the work we're doing.
I think by getting to know the patient or former patient or caregiver, and you kind of know where they're at and checking in with them, asking, how was that for you? Did it bring up anything to you? And if they start to share, tell me more, give me more information about that. What was so, I don't like to use the word trigger, but that's all I can come up with at the moment. Was there a trigger in that conversation or in that focus group that, upset you? I personally actually love talking about brain injury and, the aspects of it, but other people do get re-traumatized by it. And it's just trying to find that right mix, the right person at the right time, which is key. And I love your metaphor about pulling back from a parking spot because we're never the same after a trauma. It's impossible.
Yeah, I think one of the conversations to have is not try to answer the question, but just how are you feeling or think about this? Listening.
Just not being afraid to ask.
Just outright ask it. All right. Well, in the interest of time, why don't we open this up? I'm sure there are questions from the floor that have or online. Yeah.
Good morning. Dr. Nicholas Cozy, EMS, an emergency physician representing the American College of Emergency Physicians. Just want to really thank you for your time and your expertise. One of the things that I consistently was pondering when you were discussing your experiences as well as your family's experiences was hear me, see me, listen to me. Those were the three things that continue to echo in my mind. And by humanizing you and your family, you're also giving us an opportunity to humanize ourselves. And I think regardless of what specialty or what calling we have in medicine, I think that's a banner upon which we can all get behind. So thank you for your time today.
Hi, again, thank you. Like you said, I'm Susan Becker. I'm with the American Burn Association, the Director of Quality and Research. One thing I heard was communication is extremely important for you and your families. But I'm curious, were any social worker involved in your care? Were you referred to a trauma therapist at any point? Or were you really left to handle this all on your own and find your own resources? Because a social worker or a trauma therapist could have helped with that communication and made your journeys a little more comfortable.
I reached out to the hospital afterward and spoke with first someone from patient experience, and that did not go well at all. And there were no other resources as far as I could tell from that particular place.
At the hospital, the only time where I really had a representative that was helping, that was unbiased, at the time was to help me transition and identify a place for transition from hospital to rehab. So no, there wasn't that. But after the whole event, my injury happened in Colorado. There is a crime victims compensation program. And it's not just monetary, but they also try and connect you with services like therapy and many other organizations to try and help you heal.
My journey was over 20 years ago. And since then, I have seen that things have changed. In addition to just being able to pick up the phone, get an interpreter, to have access, they have developed programs with the social workers, trauma survivors, your visitors. So there's much more than just laying in the bed wondering what's going on. There are people you can listen to and that will listen to you. That was it. It's an evolution, not it takes some time for those things to happen, but they have been proven that they do.
So our accident was over 22 years ago. So the social workers, no. I mean, there was a social worker, but she mainly handled, as my husband would say, she just kept shoving lemon bars in his face and doing the insurance. That was, and the insurance was a big deal. I mean, I didn't have the brain power to figure that out at that point. And not even, I think my biggest complaint was the discharge from inpatient rehab. There was nothing. I mean, I had to request that the doctor come back in their room to actually tell me what I was supposed to do once we got home. I mean, I had a child who couldn't really walk stairs. She was ambulatory at this point, but her speech was not 100%. And I had no idea where we were supposed to go, what we're supposed to do, what therapy she should be having. And I had to piece it all together myself. And I did. And again, 20 years ago, not a lot of pediatric therapists specializing in brain injury. That was like a needle in a haystack. Hopefully it's a lot better now, but I lived within a metropolitan city. So it wasn't even that I was in a rural area per se. So a lot of it was me just pounding the phone because at that time, the internet wasn't what it is today. There were no smartphones. I mean, I think it would be such a different experience now than then. And as far as trauma therapy, it wasn't until about 10 years ago I even heard the term. And I would have loved to have been able to do, I've done my own, but when you're working with when you have a child and there's anyone who's a parent knows, you get to a certain point and you can only control so much. And when they will not enter into that type of therapy, because they just they don't see the trauma, but I see it.
Could I just offer one last thing? Oh, sorry. I know we're here and we have a lot of criticisms, and those are hopefully only going to help and propel some of this work. But there is a lot that also can help this work, and that's the things too that should be celebrated. Like I was treated, there were physicians that came by and checked in on me. They might not have been the surgeons that performed the work, but the things that stood out most to me were those that were checking in on me from a communication standpoint, and then also the nurse practitioners that took care of me every single day. We developed a really close bond, and that's something that shouldn't be overlooked because they are faced with or know that they have to then become that person for all the patients, and they should be celebrated for that.
And just to be clear, like I said, I certainly, I'm going to guess my colleagues in the room, my physician colleagues or provider colleagues in the room, don't take these as criticisms at all. These are things we need to know about. Because if we don't know about them, we will never get better. So thank you guys so much for sharing everything you have. I think we have time for a couple more questions. One question.
Yeah, and I'm Ben Zarzer. I'm a surgeon researcher and also suffered an injury too, but after I was a surgeon. So but it changed the way that I interact with patients on rounds. So, and you talked about it, really understanding, being mindful of somebody who's struggling and then engaging in that moment, and that it takes time to do that, and that people sometimes are rushing around and miss out on that. So I think that's something that we, from a guideline standpoint and implementation type of thing, being able to take that time to do that is really important. And if any ideas about that, that's question one. And the other piece to this is one of the things I researched even before I was injured was how people change after your injury. So like what happens to them 6 months, 3 months, 12 months down the road. And a lot of folks seem like they're doing okay when they get discharged from the hospital, but then a few weeks later, they have a breakdown. So we've developed programs to try to help those folks and detect that. But getting people to stay engaged during that intervening time when they seem like they're doing great and hey, we don't need you, so keep checking on me every couple of weeks. How do we encourage folks to maintain engagement so that if there is a stumble, we can be there to help? And what types of things can we do to help in that sort of later period? So we can be there to catch you if there's a fall.
That was 2 questions.
2 questions.
Which one you
Sorry.
want answered? Anybody have thoughts on how we can maintain engagement in people in the kind of post-acute phase, make sure that we're capturing people who are struggling?
What I hear in that question underlying it is, how are you creating a culture of connection? And that has an ebb and flow to it. So I think just honoring that there will be phases of strong engagement and strong participation, and then there will be phases of retreat, phases of withdraw and rest, just like is healthy for any human. So if you're trying to design for a culture of connection, a culture that really is considerate at the individual level, that really is something that is embedded in a training that is going to be focused on the signs of connection, reading the cues at many different levels. And I think that kind of training does help and go a long, long way in helping us implement what we know into action.
There's a huge opportunity at the point of discharge to be able to explain that there are perhaps certain stages to the individual's recovery and giving them resources for who to reach out to when they're maybe experiencing those things would be extremely helpful.
Doctor said to me, "How are you doing?" And I said, "I'm okay." He said, "That's all right. But if it's not that way tomorrow, that's okay too. So let us know." Just knowing that I didn't have to put up the brave front and act like everything. I'm okay today. It doesn't have to be that way. It may not be that way. So when I needed to talk, it was there.
We don't know what we don't know. And no one, warned me of what to look for. No one warned me like, well, she's 3. So there's a lot of developmental, stages to go through. There's going to be, ebbs and flows, and you're going to hit a rock bottom at some point, and you are going to be, your whole family is going to be really struggling. And we did hit that rock bottom, and I had to dig out and figure out how we could get help. And even now she's 25 years old, and I have no idea what her trajectory is. Don't know if she'll be independent, but no one ever said to think about those things ahead of time. And I just kind of fudged my way through it. My husband and I should say, fudged our way through it until we could figure out what was going to work for us. So I love the idea of, talking at discharge, these are the things you might want to look for. These are the things, places you can, reach out to if you need assistance and help, and just keeping that communication open all the time.
Well, let me just take the opportunity to thank you all so much. Many of us are up here presenting our work for our research, and we realize that you are up here presenting your personal stories. And I'm so grateful to you all for that. Thank you all so much. Please join me in.